Hello, everybody. Good morning.
Good morning, sir.
Thanks so much for the good work of yesterday, and we prayed that we put in our best today to make it better. The beginning may be challenging, but as we gel together, chances are that things will get smoother. And it's also a great pleasure to welcome those who are in the house already. Thank you. Wishing you a nice day.
Thank you, sir.
Okay, so we have 9 minutes more. Can somebody send a message to Dr. Issa while we try to do housekeeping? I don't know, I'm not, okay, let me migrate to laptop so I can try and see everybody. I want to try and locate the agenda and then put it before Dr. Issa joins.
Dr. Issa is already in the room.
Oh, wonderful. Thank you. Okay. Mr. Shala, give us opening prayer. We have just 3 minutes more.
Father, we thank you for this workshop. Thank you for the success of yesterday's meeting. We commit this morning workshop into your hands. We ask, oh God, that you help us. Bless this work and bless our patients for whom we are doing all this. And let all the glory be returned to you. In Jesus' name, we have prayed.
Amen. Thank you very much. So I don't know where Dr. Issa is going to be able to share his presentation from. So I was looking for where panelists are so that when it's time to share his presentation, they will not be looking for it.
He's
And then
already
I
a
would like
panelist.
It's already a panelist. Okay, thank you. I would also like to have his present. Okay, as a backup. Okay, fine. But I wouldn't want it to be shared now because we need to introduce him. So if that can be shared, and then we can introduce him. We have a few minutes. Thank you very much to introduce him. I'd like us to please go to the community and send the message that we're about to start. I want people to please come in so that people will not start struggling.
Recording in progress.
I just joined on the laptop. Mr. Shola, I need to share the agenda. Please unmute me on the second device. Okay, thank you. So I can now unmute myself. So I'm going to be sharing quickly the two agenda. And it is 7 o'clock on the dot, so I'm just going to quickly do that. Okay, good morning, everyone. It is 7 o'clock on the dot Nigerian time and 6 o'clock Ghana time. And I truly want to appreciate all the over 200 and something that I saw just a few minutes ago that have joined. I want to thank you so much for your dedication, commitment. And we want to thank God for taking us to sleep and for waking us up this morning. The first thing we have to do is to take us through the agenda for today. And that is what I'm displaying right now. I have introductions and welcome. I've welcomed all of us, and once again, we are welcome. That is welcome. About introductions, I'll be doing that shortly after displaying this agenda. And this morning, we are going to be having a presentation on introduction and overview of sickle cell disease. We're going to be having some information about the pathophysiology, signs and symptoms, which many of us have known before. But it's important to refresh our mind, and it's important because knowledge is new every day, to pick whatever is new from what we are going to be hearing. And please take notes. We are going to have post-test at the end, and so we want you to please listen attentively. And if you have anything you want to say, kindly go to question and answer section and put it there. Two things are very important this morning. Number one is that we join on time, and for over 339 of us, 358 of us who have joined, because once it is 500, it will cut off people. So it's very important that we join, and I thank of us who are in. Second thing is to watch out for attendance and make sure we sign in that we attended. Otherwise, it will count against us. Remember, yesterday I said about 3 things that the attendance is going to be used for. There's no other way we can, as professionals, we need facts and figures to act. And in the question and answer session, if you have any question concerning the presentation, please be kind enough to drop it in the question and answer section, and we'll pick it up from there. We hope to close latest by 9 a.m. on the dot. The major activity for this morning is 15 minutes for introduction and welcome, which is what I'm doing presently. 1.5 hours for the presentation. It can be less, but it can be more. We have 15 minutes for the question and answer, and 5 minutes will be closing. To take us through the question and answer section is Dr. Millicent Ogun, who is the moderator for this morning. And then I'll be coming back to close. My closing is not going to be nothing than to just say thank you for the time with us. So let me quickly introduce to us our dynamic speaker for this morning. Ladies and gentlemen, meet our resource person for today, 21st June 2025. He is no other person than Dr. Hezekiah Alkali Issa. He is an associate professor of hematology at the University of Abuja and an honorary consultant hematologist University of Abuja Teaching Hospital, Gwagwalada, Federal Capital Territory, Abuja. He is affiliated to the Center of Excellence for Sickle Cell Disease Research and Training, Chester, University of Abuja. He's a member of the Nigerian Society for Hematology and Blood Transfusion, NSHBT, College of Nigerian Pathologists, and the Secretary of Sickle Cell Support Society of Nigeria. Ladies and gentlemen, colleagues and dear professionals, kindly join me in welcoming Dr. Hezekiah Alkali Hisa as he takes us through the presentation for this morning. I've just stopped sharing so that Dr. Isa can go ahead and share his presentation. Thank you very much and welcome.
Thank you. Thank you for the brief introduction, and good morning, everyone. Hello, can you hear me?
Yes, we can hear
Good
you.
morning.
Thank you very much. Good morning,
Okay.
sir.
Good morning, sir.
Good morning, sir.
Good morning. So today we will be talking about sickle cell disease, an overview of it, talk about the pathophysiology and the signs and symptoms. Since it is an overview, I will touch the surface, the investigations or diagnosis, some lab investigations that can be done to make a diagnosis just at the surface, because in our subsequent modules, we are going to talk in details about those ones. And we'll also outline the treatment or management. So by way of introduction, sickle cell disease, the clinical manifestations arise from the tendency of the hemoglobin to polymerize and deform red cells into the characteristic sickle shapes. Sickle cell disease results from the inheritance of two abnormal allelomorphic genes controlling the formation of the beta chain of hemoglobin, one of which is the hemoglobin S gene. Example of sickle cell disease include hemoglobin SS, otherwise known as the sickle cell anemia, hemoglobin SC, hemoglobin SB, thalassemia, S-beta thalassemia, hemoglobin SD Punjab, hemoglobin SO Arab, hemoglobin SE, and so on. And these examples are not exhaustive. There are so many of them, but many of them are not clinically significant. The most common of them all is hemoglobin SS, that is sickle cell anemia. It is the most common type of sickle cell disease and the most severe form of it. Sickle cell disease is an autosomal recessive disorder. The diagram on the right is showing us possibilities that of giving birth to offspring with or without sickle cell disease. Autosomal recessive means that, there must be two of the sickle cell gene inherited, one inherited each from each of the parents, for the disease to manifest, for the individual to have signs and symptoms of the disease. So the two sickle genes must be there, or one of the sickle gene must be there with another abnormal gene. That will be heterozygous form. So this diagram is showing us some example. For example, a parent or a man and a woman with AA, a man with normal hemoglobin AA and a woman with hemoglobin AS. If they get married, meanwhile, the hemoglobin AS is known as the sickle cell trait. It is not a disease. So, but an individual with AA and another with AS, with the woman, as in this diagram, if they get married, they can, for each pregnancy, the possible baby, they can give birth to a normal AA baby or a baby with sickle cell trait. These are the two possibilities. For each pregnancy, there is 50% chance that they can give birth to an AA baby and 50% chance that they can give birth to an AS babies. They won't give birth to a sickle cell disease baby because, as I mentioned, it is a recessive disorder. Then we move to the second diagram below. We can see the man has a sickle cell trait and the woman also has a sickle cell trait. So when they are giving birth to offspring, for each pregnancy, these are the possible genotype that they can produce. We have AA. It's possible they can give birth to an AA baby. It's possible the baby will turn out to be AS. And there is possibility, 25% possibility of the baby being an SS, that is having a sickle cell anemia. So there's, for two sickle cell trait couple, for each pregnancy, they have a 50% chance of giving birth to a baby with sickle cell trait, 25% chance of giving birth to a baby with SS, and 25% chance of AA baby. So, and we can also continue with the permutation. Imagine a patient who is a man with AS marrying a woman with SS, that is the sickle cell anemia. So what would be the possibility? For each pregnancy, there will be 75% chance that they can give birth to an SS baby and a 25% chance to a sickle cell trait baby. So those are the possibilities. And you should note that each of those possibilities is per pregnancy. So it's possible that a man with AS and a woman with AS, when they marry and they have 3 children, because it is per pregnancy, it's possible that all their children can be AA, right? And it is also possible that all their children can be SS because the chance is per pregnancy. Just a little case scenario. Last year, we had an adult patient, a woman that was admitted into the adult ward with she has sickle cell anemia, and she presented in crisis, and she was admitted into the ward, into the adult ward. I am an adult hematologist. So when we went for ward round to see her, we were told that she went to the pediatric medical ward. We said, what did you go there to do? They said that her baby was on admission, and that baby too has sickle cell disease. The baby was, in fact, the baby was first admitted in crisis, and when she was taking care of the baby in the ward, she also developed crisis, and she was also admitted into the adult ward. So in this scenario, the possibility is that the husband is AS and she is SS. And when they gave birth to the baby turned out to be AS. So, and this underscores the importance of premarital counseling, genetic counseling, and screening. It underscores the importance of even newborn screening, and it underscores the importance of this very course that we are doing. Sickle cell disease is the most common genetic disorder globally, with high incidence rates in Africa, India, and the Middle East. In fact, sub-Saharan Africa is the home to sickle cell disease. The sickle cell gene frequency varies from 15 to 25% in sub-Saharan Africa. That is the threat. In fact, it is more than that in some countries. In 2021, the Global Burden of Disease study estimated that 7.74 million people were living with sickle cell disease, and projected that this number will continue to rise, especially in sub-Saharan Africa in the coming decades. Hemoglobin S arises from a mutation substituting thymine for adenine in the 6 codon of the beta chain gene at the DNA level. We have GAC, looking at the diagram on the right, to GTG mutation. This causes the coding of valine instead of glutamic acid in position 6 of the beta globin chain, giving rise to hemoglobin S. And hemoglobin S polymerizes in hypoxic conditions. It also undergoes marked decrease in solubility and increase in viscosity, forming gel-like substances containing hemoglobin crystals known as tactoid. However, polymerization is reversed when normal oxygen tension is restored. As we can see in this diagram, this is hemoglobin S oxygenated, and when it is deoxygenated, it can polymerize, but it can also reverse, especially if the deoxygenation is transient. But if it delays or is prolonged, the hemoglobin goes on to form tactoid, which polymerizes, and the polymers go on to distort the shape of the sickle cell, and gives it the sickle cell shaped. I mean, it distort the membrane and the shape of the red cell, giving it a sickle cell, the characteristic sickle cell shape, as we are seeing in this diagram. Cellular hydration is maintained by two principal mechanisms, and it is important whether it is a sickle cell red cell or normal red cell. Cellular hydration is very important to keep the red cell functional and to be able to deliver oxygen to the tissues. In sickle cell disease, the sickle red cell has limited ability to function in terms of cations and water hemostasis. There are two principal mechanisms that are involved in maintaining cellular hydration. No, the first one is the calcium-activated potassium channel, also known as the Gardner's pathway or Gardner's channel. There are about 100 to 150 of these channels per each red blood cell. Hemoglobin S polymerization and cell cycling lead to a localized transient increase in calcium with the opening of this channel, that is the Gardner's channel, and this results in large loss of potassium with accompanying movement of calcium and water, thereby causing dehydration. And this wasn't the cycle, it becomes a vicious cycle of sickling. The next is the potassium chloride co-transport system. The activity of potassium chloride is prominent in erythrocytes, in young erythrocytes, and minimal in older RBCs, that is red cells. It is markedly affected by pH, and a decrease in 0.1 pH, that is acidity, is sufficient to induce significant potassium loss via this pathway. So,
Dr. Issa,
yes?
please hear me. Could you go on slideshow? Some of the
Okay.
participants are complaining they
Okay,
can't.
are not in. Okay.
Sorry for that, please.
Yeah,
Thank
sorry.
you. That's okay.
Okay. Sorry about that. Can we see the slide?
Yes, yes.
Okay. So the potassium chloride transport system is affected by pH, and a decrease, it's more even a little decrease as little as 0.1 is sufficient to induce significant potassium loss via this pathway. Erythrocyte magnesium content is an important modulator of the activity of this system. That is the potassium chloride transport, co-transport. Increase in cell magnesium above the physiologic levels produces a marked decrease in the activity of potassium chloride co-transport, as we can see in this diagram. So the movement of these cations across the red cell from inside the cytosol of the red cell to outside is usually accompanied with by water, causing cellular dehydration. And these are the systems that can lead to that. That is the channels, that these channels we are talking about, the calcium activated potassium channel and the potassium chloride co-transport system. And with acidity, hypermagnesemia, cellular magnesemia, and the other pathways involved in sickle cell dehydration include deoxygenation-induced sodium and potassium pumps. And the other important factor is oxidative damage of the cell membrane. All of these can lead to potassium loss and subsequently dehydrating the red cell. Then we have effect of nitric oxide. Nitric oxide plays a major role in vascular hemostasis. It is critical. It is a critical regulator of basal and stress-mediated smooth muscle relaxation and vasomotor tone, endothelial adhesion, molecule expression, platelet activation, and aggregation. Nitric oxide play a role in all of these. Excessive cell-free hemoglobin after saturation of haptoglobin and hemopexin in the plasma result in the consumption of nitric oxide by hemoglobin-mediated nitric oxide scavenging. So in the diagram, we can see hemoglobin in red cell being hemolyzed and releasing hemoglobin into the circulation. Normally, this free hemoglobin that is released is mop up or scavenged by, is taken up by haptoglobins or hemopexin. So, but in a situation where we have excessive hemolysis, the haptoglobin and hemopexin will be saturated. And so we have excess of free hemoglobin circulating in the system. And this free hemoglobin mops up nitric oxide, whose function is to cause smooth muscle relaxation and keep the vessels patent and dilated. So when nitric oxide is depleted by this mechanism, the tendency is that we have vasoconstriction. The vasomotor tone of the vasculature will increase, and there's some form of vasoconstriction, which will lead to stasis and will precipitate, sickling. Then additionally, the hemolyzed red cells release arginase, and this arginase combine or deplete arginine, which is a substrate for nitric oxide production. So this is another way of depleting nitric oxide. So a deficiency of nitric oxide created by these mechanisms may underline complications associated with sickle cell disease. And the clinical phenotypes that are usually results from this mechanism or from this pathophysiologic pathway in sickle cell disease can lead to non-hemorrhagic stroke, pulmonary hypertension, priapism, and leg ulcer. This nitric oxide depletion has been known to be responsible for causing these clinical phenotypes. Excuse me. Then we have cell-cell interaction in sickle cell disease. The genetic mutation in sickle cell disease that we saw earlier leads to formation of sickle hemoglobin within the red blood cell and does not affect other cells. That mutation only affects the red cell. However, increasing evidence that there is indirect effect of this mutation on other cells, which may be important in the pathophysiology of sickle cell disease, and probable explanation of the heterogeneity in patients with this disease. There is interaction between sickle red blood cells and the vascular endothelium, as well as platelets and leukocytes in activation of these cells. So we have cell-cell potential factors in cell-cell interaction include endothelium, red cells interaction, hemolysis, the sickling, the sickle cells themselves, they interact, they cause some form of injury to the vascular endothelium, and it leads to cell-cell interaction, indirectly, affecting the other cellular components of the blood and even the vessels. We have adherence or adhesogenic molecules, and these include alpha-4, beta-4, VCAM as vascular cell adhesion molecule 1, or alpha-2, alpha-4, and beta-4, fibronectin. Here we can see fibronectin, how they are adhering to each other. This is the red cell membrane, and this is the endothelium. So the VCAM molecule, the glycoprotein by platelets, CD36 molecule, alpha, gamma, alpha, zeta, the thrombospodin produced by the platelets, von Willebrand factor. All these are molecules that enhances cell-cell interaction. Then endothelial cell function. And when this interaction occurs, it can lead to initiation of polymerization, and it can lead to vascular vessel constriction, and it leads to sickling and propagation of this sickling by other cellular components of the blood coming in together to aggregate and then worsen the sickling process. And then there will be ischemia and subsequently the other complications that follow. Then hemostasis also play a role in the pathophysiology of sickle cell disease. We know that sickle cell disease is actually a hypercoagulable state, because looking at the diagram on the right, we can see the Vacos triad that plays a role in thrombosis that is needed for thrombi to form. We know that there is stasis, endothelial damage, and hypercoagulability. So all these are seen in sickle cell disease. Stasis from the depletion of nitric oxide that leads to constriction of blood vessels, and then even the sickling itself that can form a plaque, the cell-cell interaction the damage to the endothelium by some of those inflammatory molecules, injures the endothelium. And then there are hypercoagulable state, the exposure of phosphatidyl exposure, can trigger the coagulation system. Exposure of tissue factor due to injury of the cells and tissues from the sickling process can trigger the coagulation system. So all these three components are present, usually present in sickle cell disease, making it a hypercoagulable state. And this also play a role in the pathophysiology of sickle cell disease. So talking about the clinical features, as we mentioned, all the pathophysiological pathways that we've seen, they ultimately lead to complications in all the organs. Almost every organ and system is affected by sickle cell disease from those pathophysiological pathways that we saw earlier. And these complications can be divided into acute and chronic. You're looking at the diagram, the blue complications represent chronic complications. I mean, the blue
Please, I cannot hear anything from my end. Am I the only one?
I can't see anything for now.
Okay, let's give him some time. I think it's network.
Let's just hold on. It's likely from the presenter. Let's wait a little bit.
Please, while we're waiting for Dr. Issa to come back,
The
attendance is on the poll.
Okay.
Just click on it and fill your attendance. Please put your name as you would like it to appear on your certificate. Thank you.
Please take note that your name, how it appears on this attendance, is the way it's going to appear on the certificate if you make it to the end. There's not going to be separate paper or something for attendance. So write it legibly, clearly, how you want it to appear. First name first, middle name, middle, last name, last. If that's how you want it, please make it clear. Thank you. And let us do that now.
Hello, can you hear me?
Yes, we
Yes,
can
you're
hear
welcome back.
you, but we
Okay.
lost you before. Welcome.
Okay, thank you. So vaso-occlusive crisis is one of the major or the commonest, is the most commonest presentation in sickle cell disease, the sickle cell, especially the homozygous form of the disease, sickle cell anemia, and is characterized mainly by pain, bone pain, and pain may, and depending on the organ that is affected, there can also be pain in that organ. Dactylitis, it can be associated with swelling too, like in dactylitis commonly seen in children. And hemolytic crisis, the main sign and or symptom is jaundice. They are usually deepening jaundice depending on the severity of the hemolysis, and patient can also say that he's passing dark urine. Sequestration crisis is associated with easy fatigue, pallor, symptoms of signs of anemia, tachycardia, and a rapidly enlarging splenomegaly, and is also mostly seen in children. And aplastic crisis present with easy fatigue, pallor, headache, tachycardia, palpitation, and it may be associated with fever or preceded by fever, because the most common precipitating factor is viral infection with parvovirus B19. So it can be associated with fever. Sorry, my slide is not moving. I don't know what is happening.
You can take it off slideshow.
Okay, let me okay.
And after moving, you can go back.
Okay. Okay. It is still not moving. Sorry about that. Stop sharing.
And you are still on slideshow. You didn't. If you take it off,
the slideshow. Okay. Okay.
It may work.
Okay. Okay.
Right click on the cursor.
Okay.
When you right click on the cursor, it will bring end show. Click on end show. Thank you.
Okay.
Okay, try to move the slide now. So if it's moving, we know.
Okay, it's moving.
Okay.
So I can go back to slideshow now. Okay. 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 So it's moving. Thank you. So I'm sorry about this interruption. So other acute events like acute chest syndrome, the patient will present with dyspnea, cough, and when X-ray is done at presentation and later repeated, it can show new infiltrates on the chest X-ray. there may also be associated chest pain. Patient can also present with acute cerebral syndrome due to ischemic stroke. This patient will present with symptoms such as sudden severe headache, difficulty in speaking, loss of consciousness, and neurological deficits depending on the part of the brain that is affected. Can subsequently also present with seizures. Increased susceptibility to infections, especially encapsulated bacteria, leading to fever, osteomyelitis, and so on. And priapism, which is they can present usually in teenage boys with sickle cell disease. They present with unprovoked and prolonged sustained penile erections, which may be associated with pain and tenderness, and is usually episodic or recurrent. And chronic complications in the CNS can be due to retinopathy, visual defects, hearing defects, seizures, and cardiopulmonary complications include pulmonary hypertension, which there may be breathlessness, easy fatigue, palpitations, leg and ankle swellings, chest pain, and so on. Patient can also present with asthma, especially in children. And we know the signs and symptoms of asthma, which is difficulty in breathing, and episodic, and there will be wheezing, and so on. Then we can have musculoskeletal complications, which include chronic osteomyelitis, leg ulcer, avascular necrosis of the bone, nartopathy, frontal buzzing, and so on. The diagram is showing a young lady with some degree of nartopathy here. There is malocclusion of the teeth. Here in the diagram below, we can see the avascular necrosis. This because of interference with the blood supply of the head of the femur, and it can also affect other bones too when the blood supply is affected due to ischemia resulting from sickling process. Other chronic complications in the GIT include autosplenectomy, peptic ulcer disease, cholelithiasis, and so on. Renal complications include polyuria, nocturia, hypostenuria. There is inability to concentrate the urine, frequent urination, hematuria, both microscopic and gross hematuria has been reported, hypertension, fatigue, pallor, facial or peripheral edema. And we can also have endocrine complications which present as growth retardation and infertility in some. So, as I mentioned earlier, I will just run briefly through some laboratory tests that can be conducted for sickle cell disease. We have peripheral blood findings, usually normal in the newborn period. Sickle cells in blood film by 3 to 4 months can be seen as the hemoglobin F declines. Other features include target cells, promesia, nucleated RBCs, microcytosis can also be seen, especially if it is a hemoglobin S beta thalassemia. So we can see target cells here in this diagram. These are sickle cells, Then in terms of making diagnosis, we have the screening tests such as sickling test, solubility test, and these days we have the point of care tests that are based on antigen and antibody reaction. These are screening tests, and they only suggest that there is hemoglobin S in the sample, including hemoglobin AS2. In solubility test, we can see that some of the sample will precipitate and some will be soluble in the test tube. Then we have confirmatory tests for sickle cell disease. This includes hemoglobin electrophoresis, which can be done at a pH of 8.4 cellulose acetate at pH 8.4, and then the citrate agar type at a pH of 6.2. The downside of this test is that it cannot distinguish between hemoglobin SS and hemoglobin S beta thalassemia, and it is a qualitative test. It is also affected by blood transfusion. Then we have isoelectric focusing. It uses a similar principle with electrophoresis. That is the separation of the hemoglobin protein depending on the type based on the pH and the media. When they are subjected to it, the hemoglobins are separated based on their weight due to their molecular weight, their pH level, and also the type of agar or medium that is being used, whether it is cellulose acetate or citrate agar. Then we have it is more sensitive. The advantage of isoelectric focusing is that it is more sensitive, but it is also a qualitative test. And the downside of it is that it requires a much skill and expertise to perform the test and to interpret the results. And we use of monoclonal antibodies, ELISA assay-based test. Most of the point of care tests are based on that. We have an example of type AC, sickle scan, and so on that are currently in use now. They are based on antigen-antibody reaction, and they are qualitative. We have the high-performance liquid chromatography. It is quantitative, and it is used in newborn screening, neonatal newborn screening. IEF2, the isoelectric focusing, is also used for newborn screening. Then we have polymerase chain reaction, DNA-based test, which is usually used for research purposes. It is not routinely used for service or for diagnosis. So the treatment or management is multidisciplinary. As we mentioned earlier, it affects all the system can be affected, and so it is multidisciplinary, and the treatment depends on the organ affected. A treatment can also be divided into stable state management and management during a crisis or when complications arise. This as I mentioned earlier, will be taken in detail in our subsequent modules. So this is, and generally, the patients require follow-up, whether they are stable or they are having complications, follow-up visits and continuous monitoring is very important in management of sickle cell disease. So this has brought us to the end of the discussion. We have looked at the pathophysiology, the epidemiology of sickle cell disease, pathophysiology, and the clinical signs and symptoms. Thank you very much.
Thank you very much. So the next item on the agenda is for us to have interactions on questions and answer. And I believe Dr. Millicent Ugun is in the house to go through the question and answer section and pick out any question. I have one question here, but before then, Dr. Issa, I will be glad if you can send this updated version of your presentation now to Ijoma, so she can send to us on the platform, and then we can send to the participants at the end of today. Thank you very much for your presentation. We appreciate you. It has ended early, and so we have plenty of time on our hands. But I want to warn us that other sessions may not be like this. We are supposed to be on till 8:30 and 1.5 hours, and we are done. But now we are barely finishing, like 1 hour. And that means that we have a number of minutes on our hands to play with. The first thing we have to do is to ask our questions. And I do hope that we took note of the pre-test questions in the presentation. If you had participated in the pre-test, you will have taken note of where questions came from. For pre-test is allowed to score 0, like I've said. There's no policeman that is going to arrest anyone for that. For post-test, it is much, much more serious. One, because it's our direct determinant of gain in knowledge. Two, is highly contributory to those who will migrate to the next phase of hands-on. And one other reason, which I've forgotten right now. So it's very important that for the post-test, we actually score very high. So I will allow Dr. Issa to respond to some questions. The question I have while waiting for Dr. Ogun. Please, Dr. Ogun, are you in? Is Dr. Ogun here? Can you go through the Q&A? Have you seen any question before I read the question that I have?
Yes, ma. Good morning. Good morning. Good morning, ma. Good morning, all participants, and good morning, Dr. Issa, for the beautiful presentation. There's a question from Madam Christina Sampson. She's asking, what's the most expensive laboratory tests for the sickle cell patients? Just past the question. That was the most expensive laboratory tests that can be given.
Okay.
The least expensive.
Yeah, least expensive.
Least expensive. Okay. I think for now, from I can't speak for other centers. In our center, the least expensive test is hemoglobin electrophoresis, and I believe this is the most common diagnostic test that is available in the country. It can be found in general hospitals, teaching hospitals, and it's relatively cheaper than the others. That is for diagnostic purposes. Then we have the point of care test, which are quite sensitive, but are not routinely used for diagnosis. They are still being used for screening purposes. They are not so expensive, they are affordable, but they are not commonly available. So hemoglobin electrophoresis, from my center is the least expensive. HPLC isoelectric focusing, they are only found in few centers and they are quite expensive. Thank you. I don't know whether that answers your question.
Please, can you let us know how much it is in your center? Because least expensive can
it's relative. Yeah. Yeah, the hemoglobin electrophoresis in our center is about 3,000. The last time I checked, I don't know whether it has been reviewed recently, but it was 3,000 naira. It was 3,000 naira.
Okay.
Yeah.
Over to you, Dr. Gun.
Thank you, ma'am. Thank you very much, Dr. Issa. So, Mr. Oluchi Sunday is asking, is sickle cell a sickle cell person? Can a sickle cell person be allowed to marry? Is sickle cell person allowed to marry?
Okay.
In other words, can a sickle cell patient be married to
Yes,
someone?
of course they can marry, but it's only that they have limited options in terms of selecting their or who to marry. They can not marry somebody with sickle cell trait. They should make sure that they marry somebody with AA genotype for them not to have sickle cell patient offsprings. Is that okay? Yeah.
Thank you, sir. Then Mr. Alfred Atta is asking, is oxidation damage of the cell membrane important in the maintenance of red cell hydration?
Yeah.
Is the oxidation damage of cell membrane important in the maintenance of red cell hydration?
Yeah, because the oxidative damage may not, it is important, it may not outrightly just destroy the red cell. It may affect the membrane, in the integrity of the membrane. And when this happens, it activates some of those channels that we mentioned, the Gados channel, the potassium chloride core transport system, leading to potassium loss, calcium loss, and which are usually accompanied by loss of water, cellular water. Is that okay?
Okay, sir. Thank you, sir. Mr. Francis Chinwumba is asking, please, Prof, re-explain the HB electrophoresis as it regards to diagnostic drawbacks. Explain the HB electrophoresis as it regards to diagnostic drawbacks.
So as I mentioned, the HB electrophoresis, the principle is that it separates the hemoglobins base. Hemoglobin is a protein, and it separates the various types of hemoglobins based on their on their based on their size and then their amino acids. We mentioned that AA is the beta chain is glutamic acid, while the sickle cell its hemoglobin is valine. So that gives different charges, so the electrophoresis, when these hemoglobins are subjected to electricity and the pH gradient, whether cellulose acetate or citrate agar, they separate based on their charges and their weight at different speed, and then they will be separated into bands, right? So based on that, using controls that have been established before, you can now say that, okay, this one is hemoglobin S, this one is hemoglobin A, this one is hemoglobin F, and so on and so forth. So that is the principle. So, but again, we know that it is qualitative. Is that okay? And then we also know that there are some hemoglobins that migrate the same at the same rate. So hemoglobin electrophoresis cannot really distinguish such variants that migrate at this different rate at the same speed, because they will move together and they will be represented on the same band on the electrophoresis. So it has that limitation. Is that okay? But when you repeat it using a different gradient, you may be able to separate those hemoglobins. They may now move at different speed, and you can differentiate them. Or if you use another method like the HPLC or isoelectric focusing, you may be able to separate them. So, but basically, that is the principle, and those are some of the limitation of hemoglobin electrophoresis. I believe we'll take this will be taken in another module, and we'll see it in detail. Thank you.
Thank you very much, sir. Another question from John Mpunda. He's asking, what is the management and treatment of sickle cell disease?
Wow, this is thank you for that question. It's a very broad question. And as I mentioned, it depends on the presentation. It's a multi-organ disease. So, but basically, as I mentioned earlier, the management, it depends on the presentation, whether the patient is presenting with acute complication, whether it's presenting in crisis or with some other chronic complications. So this lecture, the question is beyond the scope of this lecture. We cannot go on to begin to talk about the management for each of those complications, but in subsequent lectures, there's a module that will take care of that. So if we can be patient, we will get to that stage. Thank you.
Thank you, sir. Akomba Stephen is asking that you should throw more light on the HB electrophoresis as a laboratory test to confirm sickle cell disease.
On HB electrophoresis, well,
Yes, sir.
I don't know whether what I've said before, the person that is asking that question, I don't know whether he's still from the explanation that I gave earlier, whether he still needs more light, because I guess these were written questions, right? Maybe two people asking the same question. I think I have addressed that.
Yes, sir.
And then subsequently in the next module, there is specifically a module on hemoglobin electrophoresis. So don't want to belabor it.
Okay, sir. Blessing David is asking if that is saying that she's not clear with the Gados pathway and nitric oxide.
Okay. So maybe I can go back to those slides again. Just briefly, since I think we still have time.
Yes, yes, we have plenty of time.
So, okay, can you see my slides?
Yes, I can see it.
Okay. So, calcium activated potassium channel. As I mentioned, there are about 100 to 150 of these channels per red cell. Hemoglobin S polymerization and cell cycling lead to a localized transient increase in calcium with the opening of the Gados channels. So there are cations inside the red cell, including calcium. So when there's deoxygenation of the red cell, and then the cycling process is triggered, and there is formation of tactoids and subsequent polymerization, it leads to transient increase of this calcium. Of calcium. And this transient increase in calcium, intracellular calcium in the red cell, triggers or activates the Gados channel. So once the Gados channel is triggered, it results in a large loss of potassium. And potassium, when it is being lost, it is accompanied with water. There is the cellular water in the cell. HO2 also lives together with the potassium, resulting in cellular dehydration. Is that okay? So that is how the Gados channel affects the cellular dehydration. You can see in this diagram, the Gados channel, there's increased calcium level, then it opening up the channel, resulting in potassium loss and subsequent loss of water too. Is that okay?
Okay, sir. Thank you very much for that clarification, sir. Florence Shine Desier is asking the difference between HBSS and HBSB. And can HBSB present with crisis?
Hemoglobin SD and hemoglobin SC.
Yes.
Is that the question?
I think she wants to write C instead, but she wrote B.
Hemoglobin SC, hemoglobin SD. They are all types of sickle cell disease. As I mentioned earlier, they are less common, they are not commonly seen, and they are not the severe forms. The clinical manifestation is less, and I don't think I have seen any in my practice of 25 years. That is hemoglobin SD. But hemoglobin SC, we see them, and they can be quite, some of them can be severe. They present with crisis, and some of them actually also require blood transfusion, But hemoglobin SD I have not seen, but that is to show you that it's less common and is less severe. Is that okay?
Okay, sir. Less common and less severe. I hope Madam Florence has taken note of that. Mr.
Probably it is found in other parts of the world. It may be more common in other parts of the world. It's about genetics, it's about inheritance. So, but it's not common in our region here in Nigeria.
Okay, sir. Mr. Kende Olaogun is asking, what kind of family support can be given to a pregnant woman with sickle cell anemia?
Sorry, I didn't get that.
What kind of family support can be given to a pregnant woman with sickle cell anemia?
Well, this is where this kind of this course is important, and this is where health education is also very important. Family support is very important, not only to pregnant women, but any patient that is living with sickle cell disease, because whether we like it or not, most especially for us in our context in Africa, there's usually strong family ties, not only the nuclear family, but even extended family members. So first of all, health education is very important for counseling when a patient is diagnosed with sickle cell disease. The family needs to be brought together to be educated on what that means, the implications, and so on and so forth. And for a pregnant woman, the husband has to be carried along. He has to know the implication, and he has to be encouraged to give his full support, of this pregnant woman. So it is very important, and this she should be supported, in all forms, psychologically, she should be supported, and whatever she needs in terms of her medication and so on and so forth, the family should rally around and support her. And I believe this is where the psychologists come in, clinical psychologists. They need to bring the family together. As I said, it's a multidisciplinary approach when it comes to management of sickle cell disease. The gynecologists and obstetricians, the psychologists, and so on should bring the woman and her husband together, talk to them, and then give her all the support that she needs. So I think that is what I can say. Thank you.
Thank you, sir. Mr. Jayola Odunola is asking, what is the most effective and reliable screening method for sickle cell disease, especially for adults proposing marriage?
Okay. So for adults, HB electrophoresis, if it is done by competent hands, is reliable. And I said, as I mentioned, that is the most common test that is available. But if a HPLC is available, and if the couple can afford that, I will recommend that they go for that, because it is quantitative, and it is very sensitive. So HPLC, a high performance liquid chromatography, I will recommend that for them.
Okay, sir.
It's more reliable. Yeah.
Okay. Olawumi Damilare is asking, what is the laboratory test that is appropriate for a newborn baby with sickle cell? That has been answered before.
Okay.
Okay,
the laboratory test is isoelectric focusing is more appropriate. The HP electrophoresis is limited by the fact that, because of the high fetal hemoglobin that is present in a newborn baby, it will not give the true picture of the hemoglobin genotype, right? So routinely and worldwide, isoelectric focusing, HPLC, the newborn variant, they are the methods that are used for newborn screening. So those are the methods: HPLC, isoelectric focusing. But HB electrophoresis will not give you the right result. And then recently, we have the hemotype SC and the sickle scan. Hemotype SC in particular is very sensitive, so it can also be used. But as I said, it is still being used for screening. Yeah, for screening. So if the baby turns out to be sickle cell positive, you still need to go and confirm using HPLC or isoelectric focusing in the first 6 months. But after that, you can still you can use your hemoglobin electrophoresis to confirm, but it has to be done. The person running it has to be very experienced. Yeah.
Okay, sir. Susan Abo is asking the relationship between HBSS and other genotype traits, such as AC and SC.
Okay. So as we mentioned, the hemoglobin SS is the homozygous form. Both genes are inherited from the parents. One is from the father, one is from the mother, giving us hemoglobin SS, the homozygous form, which is also known as sickle cell anemia, and the most severe form and the most common form. Hemoglobin SC means that one of the parents has the hemoglobin S gene, and the other parent, whether it's the father or the mother, has hemoglobin C variant, hemoglobin. That is abnormal, So when these two abnormal come together, we have hemoglobin SC, and the genotype. So it is less severe, but it's relatively common. We see it commonly is common in Nigeria and especially in Ghana. It is more common in Ghana. In Nigeria, in the Southwest, we have quite a number of them. So thank you.
Thank you, sir. Evans Kuma is asking, is it advisable to do both the sickling test and the HB electrophoresis test at the same time?
Okay. Well, if you have a superior test, I think you just go for it. If it is available and it is affordable, I think you go for it. Rather than doing both for the cost, for the financial or economic reason. So I don't know, but as I mentioned, the sickling test, I can't remember exactly whether the sickling or hemoglobin or solubility test has a way of sorting out those hemoglobins that migrate together when you do hemoglobin electrophoresis. But even with that, I will advise that rather than doing a sickling test, if you have that challenge with the hemoglobin electrophoresis, it's better to move up to HPLC or isoelectric focusing rather than doing the sickling test. Is that okay?
Okay, sir. Kabir Bunso is asking, how do we improve our calcium and potassium hydration?
The potassium, how do we improve calcium and potassium hydration? Well, those are actually these pathophysiologic pathways are the basis for inventing treatments for sickle cell disease. One of the ways is for Gados channel. It has been known that which is activated by calcium, transient increase of calcium, especially when the sickling process is triggered. It has been known that clotrimazole, oral clotrimazole, inhibits this channel. But I think that is still being studied and it's not yet a routine thing. So then we also know that the hydroxyurea also improves cellular hydration. It increases fetal hemoglobin. Mainly, the mechanism of action is that it improves fetal hemoglobin, but it also helps in improving cellular hydration. So these are some of the ways.
Okay, sir. Mr. Evans said, how often has there been a differential diagnosis clinically between HBS and HBS beta thalassemia?
Please, Dr. Ogun, let me add this question to it. Dr. Issa, thank you for the incredible job you are doing. I want to encourage that in the next 5 minutes, we need to switch on to other things. You have done very well and we do appreciate you. So, Dr. Ogun, if you can put all the questions remaining together while I add this, because it's close to what you asked. Somebody just sent a message. He says, good morning, Prof. Thanks for such an insightful program. I was unable to ask my question. 3 decades ago, my genotype was AS. It was done at 2 state hospitals and 1 teaching hospital. I was surprised that my genotype changed to AA 2 years ago after confirmation at the same teaching hospital. My own is favorable, but what about others who may not? Thank you. That's the question. The person did not put his or her name. Thank you. Over to you, Dr. Issa.
Okay. So thank you for those questions. Actually, sometimes we have diagnostic dilemmas in making these diagnoses, depending on the test on the test method that is used. The HB electrophoresis is fraught by so many factors. Sometimes even ordinary, electric supply, because it uses electricity, and as I mentioned earlier, the hemoglobin of the patient, the blood of the hemoglobin of the patient, the sample which contains red cell, and the red cell contains hemoglobin. When it is subjected to this electric gradient under a certain pH, because that electric gradient is what will move the hemoglobin molecules, of course, based on their charges. Fluctuations, sometimes fluctuation in voltage, as we often have in this country. Sometimes even in the process of running the test, there will be power outage. Outrightly there may be power outage, and when they bring light, the process will continue. This has a way of affecting the quality of the test, and sometimes it may not be outright power outage, even fluctuation in the voltage, so it has a way of affecting that. And then it's the expertise of the person doing the competency of the person doing the test itself, can also be a problem. So especially in hemoglobin electrophoresis, that has been the experience of so many people. You are not the only one. So, and that is why there are better technologies are coming up. The HB electrophoresis, the high performance liquid chromatography, the IEF, So I may not be able to explain exactly what happened in your own case, but usually disparities like this could be due to the factors I mentioned earlier, fluctuations in power supply, sometimes even the reagents, sometimes even the machine is the right quality assurance in place in such lab. Laboratory equipment are supposed to be maintained regularly. They are supposed to be serviced regularly for them to give optimal and quality results. Is that being done? All those are all the factors, quality control measures. Sometimes some of the lab scientists that do these tests, they will just depend on their experience, solely on their experience, but it's usually required that as you run these tests of the patient samples, you run them side by side with control samples to be able to compare. Sometimes we don't observe some of these things in the labs, and all manner of interpretation or results will come out. So it happens, but one may not be able to say exactly what happened in your case.
Okay, Dr. Ogun, please, can you put all the other questions together now so that you can retain once and for all? Thank you.
Okay, ma. Kayode Ogedengbe asked, what is the importance of nitric acid? And is it the cause of vasoconstriction? Another one, Amara Susan, is asking, is it possible to have signs and symptoms of sickle cell disease not present until adulthood? And can it be diagnosed in utero? In other words, while the baby is still in the uterus, while the woman is still pregnant. So is it possible to have this sign, to not present these signs and symptoms until adulthood? And can diagnosis be made while in pregnancy? That's from Amara Susan. Then Folorunshaw Shaw is asking, I have seen a couple where the man is AA and the wife is AS and they give birth to an SS baby. Is this possible? Then Frank asked, can sickle cell anemia protect against HIV? Frank Adejai asked, can sickle cell anemia protect against HIV? Carlene, patient asked, patients exhibit signs and symptoms. Do AS signs?
Okay. So, sorry, I think you've asked quite a number, maybe about 3 or 4. Can I respond to them and then
Please go ahead. Please go ahead.
Exhibit
somebody asked about the importance of
yes,
nitric oxide, although he said nitric acid, but
yes.
what we mentioned here is nitric oxide. I don't know.
Yes, it's nitric oxide. She has, Azizat, my man, she has nitric oxide in the
oxide. Yes.
Sorry.
So it is important, as we mentioned earlier, nitric oxide is a smooth muscle relaxant and maintains the vasomotor tone of the vasculature. So when it is depleted, as the case in sickle cell disease by intracellular hemolysis and by arginase, which is also released when there is hemolysis, which mops up the arginine, subsequently leading to decrease in nitric oxide. That role that it plays in smooth muscle relaxation of the vasculature will be lost, and patient there will be some form of vasoconstriction, which will worsen the sickling process that has already started, or that is there in the background, and it will lead to vaso-occlusion and subsequently ischemia and infarction. So that is the role of nitric oxide. Then somebody said that can sickle cell, that can diagnosis be made in utero? Yes, it is possible.
In utero?
In utero, yes. It is possible by doing amniotic sampling or amniotic fluid sampling. It can actually be made, Then somebody mention that that can diagnosis be made in adulthood? Is it possible for
presentation?
to present, yes, to not present,
adulthood.
yes, to not have signs and symptoms during childhood, but will present for the first time as an adult? Yes, it's possible, because there are some of these patients that have hemoglobin S with persistent fetal hemoglobin, and they may not present early, but later in life, maybe when they're exposed to extreme conditions, they may present, for the first time as adults. In fact, some of them present with complications as adults. So we should know that the phenotypes clinical phenotypes are different from the sickle cell. The presentation from the presentation, the fact that somebody is presenting, is not presenting, does not mean that the sickle cell damage, havoc or harm that is being caused by the sickle cell is not there. You know, as we said, many have, there are different clinical phenotypes. Some will present with leg ulcers, some will present with pulmonary hypertension, there are some that don't present with bone pain, but you will always see them having jaundice, right? They'll have jaundice, this small, mild jaundice that they are moving about with. They will never complain of bone pain, you know. And some, they may not even have the jaundice, but meanwhile, the repeated sickling, you know, ischemia, and it's going on in the system without them knowing, until adulthood, when the damage has occurred and they begin to present with this, with signs and symptoms. So it's possible these patients may not have any symptom, any clinical sign until adulthood. And when they are presenting, they are already presenting with complications. So it's possible. You know, there are studies that have attested to that age at first presentation. There's a paper like that, I think, by Professor Baibili in Ibadan. You know, age at first presentation. Some of them in adulthood, 23 years, you know, 25, that is when they will present with crisis or one form of complication or the other. And when you now go to do hemoglobin electrophoresis for them, you find out that they are hemoglobin SS or hemoglobin SS with persistent fetal hemoglobin, which may explain why they didn't present earlier. Is that, I don't know whether that has answered the question.
Okay, sir. Yeah, I believe it has. Then the couple that the husband is AA and the wife is AS, and they gave birth to.
Okay.
Yes.
Husband is AA and the baby is AS. Okay, and they gave birth to SS patient. So this is, yeah, sometimes just as we shared the other one person asked earlier, sometimes there could be these discrepancies or dilemmas, you know, maybe possibly one of them that is AA, the hemoglobin electrophoresis was not properly done or was not properly interpreted. And then they gave him an AA results. I believe so. We encounter such cases, scenarios. Sometimes when we now ask the parent, which is AA, who has been claiming all along that he's AA, he cannot have an SS patient. Maybe it's the mother that is AS, and the man is AA. That was what they told him. And now they are having an SS baby, and he's profusely denying it. Sometimes just by asking him to go and repeat. We had such a case, you know, one of those cases. I'm simply asking him to go and repeat. When the man repeated, he found out that he was actually AS. You know, so problem was from the initial test that he did or something, you know, and that solved the problem, you know. And then sometimes we should remember paternity and cases, you know. Sometimes is it belong to the man, you know, because anything can happen. That is another scenario. The man may be truly AA, and the woman is AS, but does that baby really belong to the man? That is where you may have to go and start doing DNA tests and so on and so forth. So I don't know whether that answers the problem. The question.
I think it does, sir. Thank you so very much, sir. Elizabeth Sulaimon, is asking us, as part of the complications you mentioned earlier, infertility is one of them. She said, explain how infertility, explain how sickle cell can cause infertility. Sickle cell disease can cause infertility.
Please, this will be the last round of questions. 8:45, we have just a few minutes more. So if you don't mind to put the last set of questions together, we add the one question that I have here, and then that will be it. Other questions, I'm sorry, will not be able to take again. Thank you. So put all the many questions from this moment, no more questions. Thank you.
So the cause, how sickle cell disease causes infertility. Then another one is considering the fact that concentration of fetal hemoglobin, HbF, how best can we determine the genotype? And finally, Mr. Victor is asking that I know an SS patient who said during her entire pregnancy until 4 months did not have any crisis. What happened? I know a patient who said during her entire pregnancy until 4 months after delivery did not have a single crisis. What happened?
Okay, the question I have with me says, what is point of care and where are they available in Nigeria? Thank you. So we can take all the questions and that is it. Somebody here says, Sahid Akimbode, can a hemoglobin SB thalassemia result from a couple with combination of AA and AS genotypes? How about SB thalassemia 0? So those are the last questions that I picked from the Q&A session. If you can just help us, Dr. Issa, and to attend to everything at once, and that will be the last set of questions. Mr. Shola, please check the Q&A for those who are having issues with attendance. Thank you. Over to you, Dr. Issa, and thank you, Dr. Ogun. I hope I did not speak to myself. Did you hear me?
Okay, the availability.
Go ahead, please.
Okay, I will start with the ones I remember first. Somebody asked about point of care. What is point of care test, right? What point of care test, the patient's side, bedside, especially, for example, if patient is on admission, you can just go to the point of care where he is admitted and then do your test. If you are screening, you can carry your test to where the patients are in the community, to where they are being cared for. You know, that is a point of care. And the most common ones for sickle cell disease that are available now are hemotype SC and sickle scan. You know, they are the tests. If you know these pregnancy tests, they are just like pregnancy tests, the strips that are used for pregnancy tests. So they are simple, they are easy to conduct, they don't need expertise, you know, to even interpret and so on and so forth. So those are point of care tests. The availability, I would say that they are not really quite easily available for now in the country, you know, but some centers have it and they are sensitive and they are specific, good performance compared to, they have very good performance compared to the standard tests, HPLC and isoelectric focusing. So that is point of care test, you know. Then somebody asked about infertility. How does sickle cell disease disease causes infertility. You know, as we mentioned earlier, in the pathophysiology and complications, sickle cell disease affects all organs, and one of the organs or systems that sickle cell disease affects is the endocrine system, the gonads that are responsible for producing those hormones that regulate fertility. You know, when they are affected by sickle cell disease, you know,
Okay, I think that is a convenient point to stop. Dr. Issa, you have done very well, and thank you so much for the presentation and lots of response to answers. And I think it has just worked perfectly well for every one of us. Please, before you leave, make sure you sign attendance. We have just 9 minutes to 9. And by 9 on the dot, everybody should be off this platform except the LLC members who will stay behind to do a little bit of debriefing. I'll allow Dr. Ogun to give a word of thanks to Dr. Issa and to thank all the participants, especially participants from Ghana. Kudos to you. Kudos, and I mean it. The training started by 6 a.m. and people from our Ghanaian colleagues were already in. That is fantastic. It's a high level of commitment, dedication, and professionalism. I'm glad that this is not a jamboree kind of training. It's training for health professionals, doctors, nurses, pharmacists, social workers, psychologists, and other scientists. I'm really, really, really delighted at that level of commitment. So Dr. Ogun will say, we give a vote of thanks to Dr. Issa and to all you incredible participants. But before then, let me quickly give some housekeeping information. We have 8 minutes more and we are stopping by 9 dots. So the first housekeeping is to say, please make sure you sign attendance before you leave today. And 2, please make sure by 9 you are off, except you are having issues with attendance, which should be sorted, because attendance is going to be used for completion that you attended all through. So it will be a disservice to anyone who has stayed from beginning to the end and who has not been captured in the attendance. I have the attendance with me, courtesy of Mr. Shola. Thank you very much. I have 516 participants on the list of attendance for today. And so if you have attended and you have not signed attendance, kindly stay behind to do it. To do that, if you have signed attendance, you are free to leave. But before you leave, please take note that for this week, no more classes. We are going to resume next week, Friday. And the time remains 8 p.m. in Nigeria and 7 p.m. in Ghana for 2 hours. It can be less, but it cannot be more. We'll try not to go beyond the 2 hours. The second day is going to be a Saturday, and it's going to be by 7 a.m. in Nigeria and 6 a.m. in Ghana next week, Saturday. That will be for next week. I will give you further information on the community, the WhatsApp community of practice, where other information will be passed to us. But honestly speaking, I give it to you. Kudos, you have done incredibly well. and you are greatly appreciated. Let me have Dr. Ogun. Mr. Shola is sending the attendance poll now. It's right on this display. If you have not signed, kindly sign. Now, please fill it. Those people who sent me messages that they are not able to sign, they have not been able to sort the attendance, sort it now. While Dr. Ogun quickly take the vote of thanks for Dr. Issa, who is our guest speaker for this morning, and to all you incredible participants, and of course, to LOC. Thank you, and over from me. Dr. Ogun, please take it away from there.
Thank you very much, Ma. I want to say a very, very big thank you, sir, to our erudite speaker this morning, Associate Professor Issa Hezekiah Elkai. Indeed, your presentation is top-notch, and I believe every participant, and you can tell, the questions on the chat box this morning from the various participants that we could not exhaust. We want to say from a heartfelt gratitude to you that we are grateful, for your expertise, wonderful presentation, bringing it down to the level of even those who are not in the medicals. And we say that God will continue to strengthen you, and we are really, really grateful. So on behalf of the LOC members and the great participants who have been attentive from Ghana, from Abuja, and Ibadan, and from other parts of Nigeria, we say a very, very big thank you, sir. And thank you, great participants, for your time and participating actively. And we look forward to seeing you in the next session. Thank you very much. Over and out.
Thank you very much. I want to appreciate Professor Babalola, Madam Evelyn Achapong, and all the other resource persons for subsequent sessions who are in. We are so grateful and we appreciate you. We have 5 minutes more, and we like these 5 minutes to be used for checking out from the platform so that we can prepare for our debriefing immediately.
Please don't fill the attendance twice. If they are filled before, there's no need to sign in again.
Thank you. That's very cool. Thank you. Those who have signed before, please don't sign again. Only those who have sent complaints that they were not able to sign. I received a couple of complaints about pre-test. Unfortunately, the site has been locked. I don't have access to it myself from the IT office. We'll discuss at the debriefing. And take note that this webinar takes 500. So many people are sending messages to me that they are not able to log in. Once it is 500, it will log you out. So if you are in, don't go out. Don't do something in between so that you are not locked out and somebody who is waiting will just come in, and then it's difficult for you to return. I had so many complaints like that. But unfortunately, there's nothing we can do. I asked for the PowerPoint presentation. Dr. Issa, if you will just kindly send it. I asked Madam Ijoma to do that, but I've not received it. So if you could please send it. We need to send it. I would have loved to send it on the chat Q&A session so that only those who attended the session will have it. If we put it on the WhatsApp, so many people did not attend, we have access to it. And so I wanted to place it right here immediately after the session.
Actually sent, okay, I've actually gave her the presentation and together with those questions, I sent both to her.
Okay, I thought it was an updated version. That's why I was asking.
No, it's not.
Okay,
okay, it's not updated.
Okay, thank you very much. Madam Ijoma, please. Madam Ijoma, kindly go ahead and send it now. I'm sure some people must have left because I can see that the number is reducing to 360, but as many as are here can still capture it from the Q&A session. So, Madam Ijoma, can you please sign it?
She's presently not here. She complained that her phone battery was low.
Okay, thank you very much. I will check. Let me just check if it's there. I'll put it on LOC. Mr. Shola, you can put us on. I'm checking for Ijoma's so that we can place it here. Okay, I don't have it. I don't know when she sent it. It's not here. It's not on her messages to me. Dr. Issa, if you can send it to me, I will appreciate it. I don't have it here. Mr. Shola, can you upgrade Professor Walola to panelist, please? Mr. Shola?
Yes, sorry, what did you say?
Upgrade Professor Babalola to panelist.
Okay.
Thank you. Please, Dr. Issa, if you are still there, I will appreciate if you can send the PowerPoint to me directly. Madam Ijoma's battery is low, and she has not sent it to me before now, so I don't have it.
Okay, I will do that.
Thank you. Okay, we are so grateful. Thank you so much. Have a wonderful day. I have so many messages directly to me. Good morning, ma. I was logged out of the meeting and I've been struggling to check, to return. I couldn't. Unfortunately, the meeting is over and I don't have power over that. Apologies. Next week, try to get in early and stay tuned. Okay, let me just check Q&A. Somebody is still asking about thalassemia. I know someone wanted to get married and went for premarital testing. He received AS, SS, AC, SC at different laboratories. This worried him, and he discussed with him to go for HPLC. He still came out as previous. I counseled him to ensure that the lady is hemoglobin AA. What have you to say about this? You have said the best thing. That's the best thing. If the lady is hemoglobin AA, at least you are sure that you can have variants but not SS. That's fantastic. But I wonder how HPLL will come out as AS, SS, AC, SC, I don't know. If you do all the other tests and it's coming like that, assurance of confirmatory test is to you to go for this. And if it's still coming out like that, it's tough. Point of care are rapid kit-based tests. I know someone who has it in Ibadan, and we use him in SCAF. He's a pharmacist and has various point of care test kits and runs training. Yes, that is Professor Wala. There's somebody, and there's a clinic in Total Garden by Premier Hack, which Dr. Deshino facilitates. They also have point of care. I also have a PhD student who is currently working on point of care. She has quite a number of kits, but that was because Professor Nodu assisted to get those kits for her because she's co-supervising the student. I'm just scrambling through if there's any other question. Thank you, Prof. I'm a Ghanaian, and I joined a few minutes before 6 a.m. Florence Chine Ediza, thank you so much. You acknowledged for joining. I have not signed attendance. Where's the link? The link has been sent several times. Okay, once it is, okay, it is 9 o'clock. We have to stop. Please, kindly, can a new WhatsApp group be created for the participants to avoid new members joining the training every time? What does that mean? Mr. Ajibaito, what do you mean? Can a new WhatsApp group be created for the participants to avoid new members joining the training every time? Okay, we discussed that at the debriefing session now. Please, how can I get the question and answer of yesterday? So I don't know, we'll discuss that also. So have a wonderful day. I think everything on the Q&A session has been attended to. Have a wonderful weekend. Okay, somebody said it
Bye,
means
everyone.
Bye, everybody. Thank you. Bye. Okay, so LOC, we have 271, 60 participants in. Can we give
Prof,
them?
I want to suggest that we move to our own link so I can end this one. We can have a debriefing on our own.
Okay, where's that our own? Have you sent it or is it one we used yesterday?
The one we used yesterday, but I will still resend it now.
Okay, thank you. So you can close. Thank you.
Bye, everyone.
Bye.